I just wanted to talk a little bit more about the book and some of the other aspects. So I'm not a neurologist. I've never had epilepsy, thank God. But one of the things that I found interesting reading your book is that healthy brains are also prone to these fluctuations in electricity, right? Yeah. So you talk early on about phenomenon like butterflies in the stomach, but also something I've always been fascinated in, déjà vu.
Yeah. Well, I don't want to do anything to make anyone go to their doctor tomorrow and say that now I think that I have epilepsy. One is always better to downplay symptoms, in my opinion. But yes, lots of the sort of symptoms of seizures are very small, subtle things. So a very common symptom would be butterflies in your stomach. But of course, these are also things that happen to normal people. Déjà vu is a really common symptom of epilepsy. It's sort of relived memory that originates somewhere in the temporal lobe. But while these things can be features of epilepsy, healthy people get them on sporadic bases, and only if something is happening really regularly, I think, need anyone worry about it.
Right. And they're not always unpleasant experiences, because you recount some of your patients who talk about how they enjoy the onset of auras, right?
Yeah, I mean, I'm terrified. I wouldn't hate to romanticize something which is really devastating for lots of people, but not everything that happens in your brain not every electrical discharge will produce something negative. Sometimes it produces a positive feeling. So Dostoevsky has said, or definitely did suffer with epilepsy and wrote about it. He had, and I've seen many patients with things called ecstatic auras, where, and this originates in a part of the temporal lobe, where someone starts with a feeling of ecstasy. So one of my patients says that when he has a seizure, the first thing he does is he starts asking people if they feel okay, because he's asking them because he feels so wonderful that he feels sorry for them, that they don't feel as wonderful as him. So not all the feelings are negative feelings, but obviously if a seizure just stayed at that level where you just felt wonderful, you would never want to get rid of it, and people don't. But unfortunately, the nature of epilepsy is that discharge may spread at some stage, and then it will spread somewhere not quite so pleasant. But some of the symptoms are for some people are quite pleasant. And there's also, people have sort of attributed sort of a creativity to some of the things that happen in epilepsy. So I saw in a newspaper once, a journalist with epilepsy wrote that when he had a seizure, that it felt to him like the toy box of his brain had been thrown up in the air. And when it landed again, a bit of Rubik's Cube had mixed together with a bit of Lego and created something new that had never before existed. And he believed that his epilepsy gave him a creativity that in a certain state allowed him to produce something that he couldn't have created in a different state. But I again hastily add, for the most part, having epileptic seizures is not a nice thing. But really what it does to your brain is very individual between patients and sometimes very bizarre.
Thank you. I mean, before opening up, I've got just one last aspect of your book that I wanted to bring out. So it's called Brainstorm, and you very eloquently described the onset of these involuntary, uncontrollable electrical charges, these brainstorms the patients experience. But you also position yourself in the book as a detective, someone who is interpreting these stories, these narratives that patients bring to you. And you're brainstorming as well. You're trying to work out, you're trying to follow the clues. I just wonder if you could talk a little bit about both the power and the responsibility that comes with your position as that clinical encounter, because most of the patients who come to you do seem to have one form of epilepsy or another, but I think there's one at least who has been misdiagnosed. Yeah. But on the whole, I think I'm right in saying that the patients are coming to you actively looking for a diagnosis, because once they have that label, they can begin to make sense of their experiences and recover. But also a misdiagnosis can also be destabilizing to personality, can't it?
Yeah, well, I mean, you're right. You know, you're walking a tightrope at all times, because as I've tried to demonstrate, the brain is still really very mysterious to us, and no piece of information is completely reliable. So, I think that sometimes people have the impression that, you do a test and it's either positive or it's negative. So you either have a yes or a no. And it so rarely is like that. It's so much a case that you have to take all these little bits of information and try and put them together and see, can you make sense of them? And it is therefore the case that you will definitely be wrong. And that, well, I now know that August has seizures, because as MRI imaging was becoming more and more better quality images are better scanners are becoming available all the time. So at some point in this story that I didn't get to with August, we found an abnormality on her scan that helped us to confirm that she had epilepsy. But in a lot of people like August, you will never find that abnormality. So you will constantly exist in a world where I'm saying that you have epilepsy based on the story and seeing what happens. And that is, as you say, a huge responsibility, because I know that doctors want to offer labels, because if you come and see us and you've something wrong with you and we can tell you what's wrong with you, we feel good about ourselves, and then you feel better generally as well if you are given a name for your suffering. The temptation, therefore, is always to offer somebody a name, even if you're not completely sure. Unfortunately, when we do offer labels to patients, it can be a disabling thing in the long term, depending on the label that you're offering. So I would see many people who've been told they have epilepsy on quite flimsy information, but actually do not. But once you have got a label, it is pretty hard to shake it off again. So what we're doing is a huge responsibility, and I feel that when I do it, what I try to do is take my time, and I find that that's my best, is not to listen to the story once and get your impression. You're going to get a first impression, but then test your theory and think about it for a while. And I find that that's our kind of best protection against the biggest mistakes. But it is inevitable when you're dealing with an organ where we only barely know how it works at this point in time, that mistakes will be made. Don't want to scare everybody. Sorry.
Well, thank you. We've got about half an hour left for questions, so should we start here, lady at the front with the...
Hi there.
What are your hopes in terms of future diagnostic technologies?
My hopes are not for future diagnostic technologies. Not that I'm saying we don't want that, but what we're doing at the moment is we have developed quite all these scans that I'm showing people. These are all quite modern technologies that have become available to us in the last 20 years or so. So what we're doing a great job at the moment is finding new ways of scanning the brain. Oh, here's another new way of scanning the brain. But what we are doing, but have failed in so far, is finding out how to reverse damage once it's occurred and how to heal the brain. So it's an unfortunate feature of neurologists that we're wonderful at trying to find out what's wrong with people, and we're significantly less good at making people better. So my hopes really are more towards devising better treatments for people. I think we're pretty far away from that, although recent discoveries, I'm not talking about epilepsy now, just in general brain disease, multiple sclerosis, strokes, head injuries, we cannot cure these things. There are positive moves forward. So, we're aware now. We used to think that the brain was fully formed, in childhood or infancy, and that basically it didn't change at all after that time, and you never, and that it couldn't adapt. Now, it's still true that adult brains are very bad at adapting, and young children's brains are better at adapting. But we now know that the brain has some neuroplasticity and that it can change. So we're just kind of beginning to learn the possibilities, but we are quite far away from harnessing them at the moment.
Gentleman here.
Thank you for an interesting talk. You said on a number of occasions that the drugs don't work for a small proportion of people. Do you know which part of the brain, from the scans or from any other research, do you know which parts of the brain the drugs do actually work on?
It's probably...
And also why it shouldn't work to some extent for everyone.
Yeah, well, they do usually work to some extent for most people. So it would usually be the case that 70% of people, you can get rid of their seizures completely, and the other 30% you can just make them a little bit better. So they do work to some extent for not everyone, but most people. It's not a part of the brain that responds better. It's probably so epilepsy is not a single disease. It's the end result of hundreds of lots of things. So it could be a genetic condition, it could be a head injury, it could be the result of meningitis, it could be a brain tumor. So it is just an abnormal electrical discharge that happens for numerous different reasons. So it's not so much that that one bit of the brain is more responsive to drugs than the others. It's that it depends more on what caused your epilepsy in the first instance. I don't know why drugs work better for some sorts of epilepsies than others, but when people have obvious lesions on their brain scans, and we are particular types of lesions, like developmental lesions, we're less able to control their epilepsy with drugs. Now, why those particular lesions respond less well? So it's the underlying, I don't know, but it's the underlying cause of the epilepsy that presents the challenge, probably. And we don't cure anyone with epilepsy. That's the joy of being a neurologist. What you do is, the natural history for some people will be that it just gets better. And our job is to hold the tide back until it gets better. And that works for some people better than others, more based on a pathological process than a part of the brain.
More questions? Gentleman and young lady, I think, here at the front. Just here, in the middle. Yes, there you go.
Will you ever be able to cure August's case?
I think that in August's case, I think it's probably unlikely. I hope that there will be a point in the future. I think we're very far away at the moment, unless there is some miraculous discovery in the near future. But at the moment, all of the things we're doing to try and cure epilepsy just dampen down the electrical activity of the brain, all through slightly different processes. But they're all variations on a theme of the same thing. And I think if we haven't managed for her at this point, then we are not going to be able to for her. What actually is causing August's epilepsy is she has a genetic condition. So she was born with a tendency to epilepsy, which was defined by her genes. So it may be that people in the future in the near future who are very like her. So one of the really exciting parts of science where we can probably cure brain disease in the future, or is preventing it, by manipulating people's genes. So it may be that people with exactly her problem, she's had it for too long now, I think, for us to do anything for her. But I'd be very hopeful in the future that similar people we will be able to help.
This lady here, you've had your hand up twice, I think.
Thank you. What I've got to say is not just a direct question. First of all, I want to thank you with all my heart, because I'm not afraid of admitting here anymore that I have suffered with epilepsy all my life. I've been under the hospital, and I wouldn't be alive, and I wouldn't be here without people like, and doctors like Suzanne and her colleagues who trained her. What I ask everyone in this room is not to treat people with epilepsy as though they're lepers. Because the worst thing I've had to live with all my life is being treated just like that. Or you can't have a job because you've got epilepsy. You can't go here because you've got epilepsy. No, you're an alien from outer space with 3 legs, and, because you've got epilepsy. We're normal human beings. And I dare say most of you wouldn't have known if I hadn't have said. And you're not running away. The best thing about we need in this world is education of everyone. And that is so important. But carry on your excellent work.
Thank you.
And many
Thanks very
thanks.
much. Okay. Yes. Thanks so much for saying that. And also, it helps me because I need to probably reinforce the point that you're making as well. So I've got a patient who I've written about called Ray, and he has these epileptic seizures where he suddenly starts spitting and cursing. So 1 minute he's fine, and then he just starts going, fuck off, fuck off, fuck off, and then he spits. And that goes on for about 3 minutes. And again, it happens a couple of times a week. Now, he's this incredibly nice, gentle, intelligent person, and he has a great deal of difficulty holding down a job because of these attacks. Now, you might say, well, why couldn't you hold down? He can do the job, but his problem, as this lady has brought out, is that people don't want to employ him. He's begging for the employment. But in his last job, he was, of course, epilepsy is covered by the Disability Discrimination Act. It is completely illegal not to employ someone or to let somebody go because they have epilepsy. But unfortunately, people find ways around these things by giving other reasons. So he's had several jobs where he has been let go, and most recently he was told that people in the office are afraid of him. Now, this is what's happening to him is a completely unconscious thing. It's like a faulty wiring in his head that's just sort of setting off a few sparks every now and again. It says nothing at all about his personality or who he is in between times. What happens in his seizures is a manifestation of the bit of brain that's diseased. It has nothing to do with his personality or anything to do with him. It only lasts about 5 minutes a couple of times a week. He longs to work and is very motivated. But unfortunately, people just have difficulty dealing with these attacks. And that's one of the reasons that, I've written a series of these stories about my patients in Brainstorm, and they are longing to have their stories told, because you can imagine trying to explain those sort of symptoms to somebody. You wake up on the underground and you've just spat at the person opposite. Again, he's had lots of positive experiences. People are often very, very nice to him. But he is having a recurring problem getting a job because of these attacks. And as this lady says, this is just a disability like any other. But unfortunately, because it manifests in an unusual way in some people, people are frightened by it. And we need to just sort of become more tolerant of that.
Quite a few people holding up their hands. Can we take maybe 3 at once? So you and the lady in white there, and then the gentleman in blue. Yeah, there we go.
Go?
Yeah, one after the other, and then you can answer
I hope I can
in whatever order you like.
I want to thank you too. I don't have epilepsy that I know of, but I just received some bad news before coming here, and some stories about resilience have been a lesson. So regardless of if you can cure them, you've helped me. So thank you. Question-wise, I can imagine that for people that have severe difficulties and are impatient and maybe might classify their lives as not worth living in that current condition, might put some pressure to be able to act even if there is no cure. I can imagine if I were August, even if there was no cure, I'd beg to be operated.
Oh yeah, and that is what happens. Because the thing is, if you met August now, she would look so healthy, you would not believe there was a thing wrong with her. And that, of course, is a real problem for her, because no one believes she's disabled. And to her neighbors, she's a young woman who has loads of friends coming over, never goes to work, plays loud music all the time. She has constant problems with her neighbors because they think she's a certain kind of person. She would do anything. But fortunately, we would not do anything because we would leave her severely disabled. So we have to, a lot of people would like to have operations like Julie had, but we have to kind of counsel people to know when to stop, because we could very easily give someone a new disability, take away one disability and replace it with another one.
This woman and the gentleman in blue shirt.
2 short questions. This isn't cheating. Firstly, as the brain changes with dementia, you're bound to have a dementia question, aren't you?
Yeah.
Does that make the epilepsy worse, or does it in fact tend to make it less prevalent? That was the first question. And the second one is, I have a niece in her 40s who started having sudden blackouts and was then told it was to do with her heart. She's been on a pacemaker for a couple of years. All that worked. Now it's started again, and they're talking, oh, well, maybe it's a form of epilepsy. So should I buy her a copy of your book or hide it from her?
No, yeah. No, do not give... I was going to say something terrible, I might say it anyway. Give her a copy of my first book, which is called It's All in Your Head, which is about people who take this journey from doctor to doctor with medical symptoms that defy explanation. And sometimes there is a simpler explanation out there. If anyone thinks they have epilepsy, don't try and self-diagnose with my book. I've forgotten the first... oh, yes, dementia. Well, any brain disease, oh, sorry, ironic. Sorry. So basically, I'm a comedy genius. If only I did if only I did it on purpose, which I didn't. So basically, yeah, the first... any brain disease increases your risk of having seizures. So anyone who has a brain disease has a slightly higher chance of having seizures. However, as if you have epilepsy, taking dementia out of it, if anything, epilepsy gets a bit better when you get older rather than getting worse. So it's not normally a sort of progressive condition that gets worse and worse. So if you have a diagnosable dementing illness with a brain abnormality, your increased risk of seizures, but if you have epilepsy, as you get older, you have a chance that your seizures will get a bit better.
I was thinking about the August case, and when you were saying about, she runs out of the room and it's hard to kind of keep the electrodes on and stuff. So I'm thinking, how can we keep her still? Can you like sedate her or anesthetize her or something, keep her in a bed, paralyzed for a few days so you can capture it at high resolution? But I'm sure you've thought of all of that. But so the real question is that, being as though the physical manifestations are a result of the electrical impulses, if someone is physically unable to move through medication or whatever, is the electrical impulse or the blood flow, is that as intense, or is it less intense when you scan it as a result of them not being able to actually thrash around?
You mean if we did something to paralyze her?
Yeah.
If we did something to paralyze her that didn't, you can't, there's no point in sedating someone because then they won't have a seizure because sedation dampens the electrical activity in the brain. So you can't sedate somebody to record a seizure because that will change or eradicate the seizures. So that's what we do for poorly controlled seizures we can't get under control, is we sedate people to give their brains a rest, essentially. If you paralyzed somebody, you could, that wouldn't affect if you use some paralyzing agent that didn't sedate them, that wouldn't affect what was happening in their brain. But you wouldn't do that because you know that what's happening in someone's brain who has a hyperkinetic seizure like that is not going to be amenable to an operation. So it's good enough that we have enough clinical experience to know from patients. So everything depends on learning from patients of the present and the past. And we've seen enough people who have brain lesions in particular parts of the frontal lobes who have hyperkinetic seizures to know that lesions in the frontal lobes cause hyperkinetic seizures. So we're basing it more on historical patients, the story she tells us, and any more heroics than that probably wouldn't really benefit her and could put her in harm's way.
This gentleman,
Want to come over here?
Thank you. If I understood correctly, you were saying that epilepsy manifested itself as a synchronous electrical activity in the neurons.
Yeah.
I understand, it's not my field, but I understand that sleep, deep sleep,
Yeah.
also has synchronous activity in the neurons. Is there any connection between epilepsy and sleep?
No, I don't think there's a connection between them, but epilepsy does behave differently in sleep. So some people have their seizures. So yes, the electrical activity in sleep is distinctly different, completely different to the electrical activity when we're waking. And that makes people, certain people have seizures only in their sleep. So something about that electrical activity does interact with epilepsy in such a way that it behaves differently. But the actual underlying process of what's happening will be completely separate processes.
And forgive me if I may, just
another
one. When you said you removed brain tissue. Is there anything odd that you see about that brain tissue that you've removed?
I did leave out other bits of the story, and that's quite correct to ask. If anyone is going to take out a bit of your brain, please ask what does it do when it's before they do it, which is we will also do extensive neuropsychological testing on someone if we're going to take out the bit of brain to try and figure out as much as we can what that bit of brain does. So the bit of brain we would have taken out on her, which is the operation that's most commonly performed, is the anterior temporal lobe. Now, the biggest problems when you take out the anterior temporal lobe is, first of all, very important for memory. Second of all, depending on how far back you go in the temporal lobe, there are also sometimes some of the visual field runs through that. But the biggest problem is if you're taking out the amygdala and the hippocampus, which is right beside it, you risk making someone's memory much worse. So you could take out that bit of brain, cure their seizures, and leave them amnestic, so unable to remember anything. So what we do is extensive neuropsychological testing beforehand to try and figure out how good or how bad their memory is to start with. And a big clue would be that the left brain is more for verbal memory and the right is more for visual memory. So if we will do tests that try and assess her memory. If she already has a bad verbal memory but an excellent visual memory, then that means that that bit of hippocampus probably already isn't working very well. You can't guarantee somebody won't have more of a memory problem, but it's reassuring. If you've already got a badly functioning bit of brain, it's probably okay to take it out. And if you have already established that the other side is working well, then hopefully the other side will compensate for it. But the truth is that if you have epileptic seizures regularly for 40 years, it will affect the memory bit of your brain anyway. So you're going to have memory problems anyway. So taking out that bit of brain might accelerate those memory problems ever so slightly. But assuming that bit of brain wasn't working great to start with, the risk shouldn't be huge. You definitely don't want to take out both hippocampi.
Very last one, if I may, please.
Honestly.
Is it possible to conceive of a mobile device that would infer whether you were about to have a seizure or see the precursor of that and then administer some kind of sedation or something to calm the patient?
It's absolutely. It is absolutely possible that that will be something that will happen in the near future. So we already do something which is kind of a palliative treatment. It's not anything curative at all. Is that if a patient feels a warning, we have a thing called a vagal nerve stimulator that you can implant it. It stimulates the vagus nerve, which is said to reduce numbers of seizures. So a patient can, if they feel a warning, they can stimulate something themselves. But I'm sure it will happen in the near future. We'll have implantable electrodes that will be able to detect that first electrical burst and stimulate the brain to prevent the burst from progressing. So it isn't available at this time, but those kind of stimulation techniques, implantable electrodes, are already been used in other sorts of neurological diseases. I'm sure they'll find a use in epilepsy at some point in the near future. I think this man's had his hand up for ages.
Oh, okay.
Sorry, were you?
Okay, yes, please, go ahead.
Yeah, that's right.
Just a slightly different question. Do strokes and brain hemorrhages give any indication as to brain function depending on where they occur?
Yeah.
Obviously, we've had the big high-profile Alex Ferguson, and also a close friend of mine has recently had a brain hemorrhage, and I noticed anecdotally that he can't talk very much, if at all, and he doesn't really recognise his environment. Is there any kind of cause and effect there depending on position?
Yeah, when we were at the stage with Tan, who I described to you, who is a patient who suffered a stroke and was unable to talk, was one of the first people who taught us about Broca's area, which is in the left frontal lobe. So before scientists hit on this idea that epileptic seizures could be used as an exploratory tool, strokes were the other tool. The thing about strokes, though, is that they've got a limited territory. So they exist within the territory of arteries, but all of our arteries have roughly the same arrangement. So there's only a limited number of constellations of symptoms that you can get from a stroke, but there's a limitless number of constellations of symptoms you can get from epilepsy. So both things teach you about the brain. Obviously, as a doctor interested in epilepsy, I find it more interesting, but stroke has been very informative for us.
This lady had her hand up. Thank you. The microphone's coming.
You described an epileptic seizure as a discharge that starts always in the same area and then, I assume, always takes the same pathway. As a lay person, I find strange. But is there a way to just disrupt that pathway instead of
Well,
taking out.
It's possible that when we do surgery, that's all we're doing is disrupting the pathway. So we never know that we're taking out the exactly right bit. And sometimes people get better, and it may be, but they still have some minor symptoms. So it certainly is the case that we're aiming to take out the source. But, you know, as I've said, even when all of the stars are in alignment, we only know the source in 80% of, you can only guarantee. So very often when surgery makes people better, it's not because we've taken out the source, it's because we've disrupted the pathway. And then unfortunately what can happen is someone can either stay well or the seizure can find a new pathway to take and the seizures come back.
Thank you very much. Well, not about epilepsy directly, but I wondered about synesthesia, which typically takes the form of associating musical sounds with particular colours and so on, and has other forms. Does the study of that and people who have that sort of behaviour, does that help you in any way to understand these sorts of things that you're involved with?
I think it's not so much that it helps us understand what we're involved with, but you know, these kind of experiences, we're still really at the point of figuring out how the brain works. So in the not so distant past, synesthesia would have defied us entirely, and no one has proven anything about it, but we now would understand it as being to do with the connectivity of the brain, that bits are connected, that perhaps are not connected in everybody. And that's why certain people have a certain experience. It's more that we are trying to find out as we look at the brain how these things work, how these things happen, rather than these things happening teaching us about the brain.
Son's he's in his 40s now. He's a classical musician. When he was a teenager, he associated musical pitches and sounds with colours, and at some point we sort of discovered this, and he said we thought everybody did.
Yeah.
And
Well,
was quite astonished to find that it wasn't the same with everybody.
And that's an important point as well. It's important that, you know, all our brains, we're increasingly realizing that, you know, we used to pay an awful lot of attention to just say bits of cortex or the neurons, whereas now we realize it's so much more important is probably the connectivity between different areas of the brain rather than a single area of the brain being important for any one action. It's how the different areas connect to each other. And that will be different in all of us, and it's important we don't pathologize difference in that way.
There's a gentleman at the top here, second row, down. Yes, okay.
Thank you for your talk. I was just curious about how the electrical discharge, or how is it understood that the electrical discharge starts in the first place, and what sort of work's being done in that area?
Well, there's loads of work being done in that area, and I think the answer is that it's, again, this isn't a single disease, this is multiple different diseases. So some of these things are what we call channelopathies. So the channels are, for those who don't know, are you know, the electrical discharges are produced by the movement of ions like sodium and potassium, etc., in and out of cells. So sometimes this disorder is a problem in the channels, and it is a channelopathy. The channels aren't working properly, so they're producing an instability. But I think, there's loads of work in that area. I think it's many, many different mechanisms that apply depending on the underlying pathology that has caused this disease in the first place, and those pathologies are multiple.
I think we've got time for just a couple more questions. Can we maybe take them both at once? That gentleman up there, lady with a hand up, and maybe three at once. Maybe this gentleman here on the end. Whoever gets the microphone first. I think you have it first. So.
That was a fantastic talk. Thank you very much indeed. You made that very understandable for human beings like myself. My question is around mathematical modelling of the brain.
Oh no, I can tell you already I can't answer it.
And about,
it's all very worrying.
And about whether you think with quantum computing coming in, whether that's going to cure, everything.
Do you know what? You've certainly entered a field I know nothing about. But I think with all of these things, we are just constantly applying new mathematical models to produce new pictures of the brain. So I don't think that those fields of research are going to be the key. We are already, that's what happens when we are doing functional MRI, is just a statistical model that compares thousands of patients. And I think that each of these sort of mathematical techniques or statistical techniques are new ways of looking at the brain and new ways of quantifying the information we already have. But they're not going to be the game changers. They're just going to add another. So the next time that August or someone comes to hospital, she won't have a PET scan and a SPECT. She'll have yet another analysis applied to her brain, but it won't solve her problem. So I think everything is useful as a piece of the puzzle, but where we're really continuing to fail is in reversing brain disease and reversing brain damage. What was the last question?
Well, this lady's going to ask it, I think.
Hello. Can I also thank you very much. I found that incredibly interesting.
Thank you.
It was just a very simple question, because you mentioned about the chap who had uncontrollable bouts of swearing and spitting, as to whether Tourette's is a form of epilepsy.
No, I mean, I think that, Tourette's probably teaches us something about sort of parts of the brain which are involved in impulse control. But I think that the mechanism for Tourette's is probably, so they possibly are involving similar parts of the brain, and perhaps people with epilepsy who do have this impulsive behavior, we might be learning something from people with Tourette's. But I think that the mechanisms for these are completely different mechanisms, and I don't know what the mechanism for Tourette's is.
Very last question here.
Thank you. I just have a general question, really, about transplantation, actually, with brain tissue. So you spoke about replacing or possibly operating on the brain in different regions. Do you know if there's any work out there that's looked at replacing brain tissue with the patient's own cells, using stem cells?
Oh, well, there is. I mean, there's lots of stem cell research, not so much in the field of epilepsy at this point, but in the field of things like multiple sclerosis. So that is certainly, it's extremely early stages. It's extremely experimental at the moment, but there certainly is a lot of interest in stem cells, because I mean that is our problem with the brain, is how do you repair tissue or how do you grow new brain tissue? And there has been a small amount of success in a small number of experiments in people with multiple sclerosis who are basically losing myelin, and it has shown just early suggestions of success. So I think that is an area of great interest, and that's certainly again an area. I think the areas where we might feel most optimistic is gene therapies, stem cell therapies, and I think the other thing that will, in our lifetime advance quite quickly is surgical techniques. At the moment we operate on everyone by opening their skull and taking out a bit of brain, but it's entirely possible surgical techniques will advance to a point you don't have to open someone's skull, that you can direct something which is more laser related, for example, so less invasive surgeries. But certainly stem cell therapy, I think, is something that we have a great interest in. Okay.
Well, thank you very much, Susan. Fascinating talk, great questions. I, for one, take comfort in the fact that for all the advances in medical technology and PET scans and fMRI, that the stories patients tell and the names they use, and this is your own phrase, are more vivid than any medical diagnosis. So thank you very much.
Thank you.